Robot technology or robotic technology has been around and in surgical practice now for around 10 to 15 years. The advantage of a robot is twofold. One, it allows dissection techniques through a highly magnified field that takes away any surgical tremor from the individual. So what it means is that the movement by the robot is far smoother than in some cases for ultra-fine, particularly suturing techniques, for ultra-fine suturing that avoids any tremor by the surgeon. Yeah. So that has a big advantage. The other advantage is it allows access down a very narrow corridor for soft tissue dissection. And the two areas where that's been very successful is prostate surgery, which involves removing tumour from around the prostate and keeping the prostatic nerves and the prostatic vessels intact, or cardiac surgery, where the getting access between the ribs using endoscopic ports and robotic ports can be highly beneficial. One of the problems with the spine is that the robot hasn't got a good way of assessing proprioception, meaning there's no feel, there's no proprioceptive feedback from the robot. So it's very good for a soft tissue that you can pick up and move and suture. But for a structure that you're trying to drill through, which often the feeling of it, and the feeling of touching a nerve versus touching a bone versus touching a muscle is quite different. And in neurosurgery, we use proprioception quite often to work out where we are, because we're looking at a very narrow aperture where you may not be certain whether or not the structure on the other side of what you're feeling is a nerve or bone or a blood vessel. And that technology is not, is something that needs to be overcome. Robotic technology for placing instrumentation in the spine has got great possibilities, because what it can allow is, instead of having the surgeon pass the screw where there might be a slight change in trajectory, the robot promises to deliver an instrumentation piece such as a screw on a direct trajectory that will not deviate. So potentially in future that may well be very beneficial. The problem is, at the moment, the robot has no way of knowing with real time what it's putting the screw through. And so if you're placing instrumentation into a structure, the surgeon will use proprioception and experience and orientation to work out how that trajectory is going. And if there is a problem with placing the instrumentation, the surgeon can normally stop and revise the positioning of the screw based on what he's experiencing during the operation. Unfortunately, the robot has no way of doing that, nor does the operator have any way of, the operator of the robot know what he's doing. So it has the potential to put an instrumentation in the wrong position. And if the patient moves, which is not out of the question during surgery, often there is movement of the spine because it's an interlocking structure surrounded by muscles. And if you move the patient's position, the whole positioning of the guidance system, which is what the robot relies on, that is the guidance system for imaging where the patient's anatomy is. And if that patient's anatomy moves slightly, the robot will not be aware of it. So until we have real-time, continuously updated imaging of the bones and soft tissues, until the robot has that, it makes it less safe than being operated on by a human being. So the surgeon at this point is safer than the robot, for those reasons. But it will come. There will be increasingly, as the technology improves, the robot technology is at a very basic level at this point. It can really only do a couple of features, which are exciting developments. I'm going to Melbourne next month to look at the new robotic platform to see what the latest upgrade will be. And it may be something at this stage that we can seriously think about using in general.